and thank you very much for inviting me to this partially virtual annual endoscopy course in Düsseldorf. Unfortunately, I cannot join in the live event at the Düsseldorf meeting itself and not enjoy the hospitality of the Düsseldorf team. But maybe in the near future, I will be able to do so. So today it's going to be a virtual course, and it's going to be on practical lessons for endoscopists in machine learning in endoscopy. Now, artificial intelligence is all around us in daily life. We have our facial recognitions on our iPhones. There is areas where cars drive by themselves. And this is going to carry through in endoscopy as well. Now, artificial intelligence is not new. It started in the early 50s when humans started to program computers to follow certain human rules to mimic human behavior. But this process got stuck at some point until we realized that it's not by telling the computers what to do, computers how humans learn. And this is actually what machine learning is. So machine learning is not to feed the computer human rules and thus mimicking human behavior. No, machine learning is to mimic the human way of learning. So provide data to a computer and have the computer learn by itself without supervision of humans to see what comes out of this. So the practical applications in endoscopy for machine learning, a lot of focus is going through early detection. So detect what can be seen on the screen, but what is not necessarily recognized by the endoscopist, or to better characterize what has been detected, for instance, telling you if this is a hyperplastic polyp or a submucosal invading cancer that you should not resect. But machine learning algorithms will also get into your practice by providing you feedback on the quality of your endoscopy. And then there's probably a wide variety of logistical tools that you will have in your endoscopy room, either to facilitate real-time endoscopic reporting, or that on the background facilitate the logistics of your disinfection and the storage of your endoscopes. Now, here's an example of a computer-assisted detection tool, a CAT algorithm. We published this in Gastroenterology, and it relates to the detection of subtle early Barrett's neoplasia. So here are 3 cancers that have been picked up by the algorithm. Now, in order to do so, you need to feed the computer with data. And then there's actually 2 ways a computer algorithm can then extract relevant features. The first and oldest way is actually that we as humans, we tell the computer which features in the endoscopic images are relevant. And this clinically inspired approach basically works with providing the computer with an image, then asking it to cut it up in pieces, and then for each of these blocks, provide me with a number on the color and quantify texture. So basically, we're telling the computer only to look at color and only to look at texture. And for each of these blocks, we will then be able to extract an average color and a color variance, and an average texture and a texture variance. And then the only thing we need to do is then tell the computer which of these blocks are neoplastic and which of these blocks are normal. And for this, we are usually using expert delineations, as you can see on this image. Now, once a computer is told what is cancer and what is normal, it can then relate color and texture to the gold standard. And it will find a cutoff line, actually, between blocks that contain cancer and blocks that are normal for texture and for color. And then if we feed a new image to the algorithm, for each of the blocks, it will then look at what's the texture, what's the color, how do these relate. An area here would then be classified as an early cancer. A block with features in this area would then be classified as normal. So here is a new image processed by the algorithm. The green blocks are normal. The red blocks, according to the computer, have color and texture that it has learned from previous data resemble neoplasia. And then by post-processing, you get a delineation something like this. Now, such a clinical inspired algorithm works actually pretty well in Barrett's, as we have shown. Here's 4 subtle lesions delineated by 6 experts, and this is how such a clinically inspired algorithm is actually picking up these lesions. Now, the downside is that the computer, while doing this, only listens to what we have told the computer to look at. It will only look at color, and it will only look at texture. Whereas in the endoscopic detection of lesions, there may be other features, maybe that we as humans don't appreciate, or we can't give exact words to, that the computer can extract. And this is really what deep learning and machine learning now is all about. In the deep learning approach, we don't tell the computer which features it should extract from these data. No, we have the computer fiddle around with these data to find those features by itself. This is what a deep learning approach is, and it requires more images than if we just instruct the computer to look at color and texture. Now, generally, in machine learning and endoscopy, we don't have millions and millions of pictures that are actually required for a complete deep learning approach on endoscopic images only. And this is why we generally use a 2-step approach. First, we have the algorithm work on a data set that bears no resemblance to endoscopy. A number of these data sets are available on the internet, and ImageNet is a very large database that is generally used for deep learning algorithms. The algorithm then learns basic features of images from this large data set, and then this knowledge is transferred to the next step, in which the relatively limited number of images, please bear in mind, you do not only need the images, but you also need these delineations. These are pretty rare, and we don't have thousands and thousands of those. That these limited number and more precious images are then used for the refinement of the learning process. Now, this ImageNet database consists of millions and millions of images divided in over 20,000 categories. So there is 20 types of cats, there's 30 types of dogs, there's all kinds of cars, trees, schools, buildings, airplanes, you name it. And all these images have been hand annotated, telling the computer what is actually on the image. In addition, more than 1 million of these images also have boundary boxes, providing information not only what's on the photo, but also where in this photo the bird is and where the frog is. Now, distinguishing a frog from a bird is way easier than distinguishing neoplasia from normal. So in order to do this, you need an enormous amount of images and enormous amount of computational power. Because if things look alike, it becomes much more difficult logically to distinguish these two. So in this example, are you looking at a dog, a labradoodle, or at fried chicken? At first glance, you would not immediately appreciate the differences. You have to look twice to appreciate this. And once you've looked twice, your visual brain is able to distinguish these two. Now, this looking twice, or the more differentiated images, really requires the deep learning approach. Because in deep learning, we use neural networks. These are types of networks that resemble the architecture of our human visual cortex, but they have many more of these neural layers. This is something we could not do 15 years ago because our computers lacked the enormous computational power that is required for this. But in deep learning, we have the computer extract the features by itself and then have multiple hidden layers for what is called a deep learning convolutional neural network. And these layers, these neural layers, basically go through image recognition in a very stepwise approach. The initial images identify only the light and dark picture values. It distinguishes darker from lighter pixels. And then this information is transferred to the first layer that then identifies from this light and dark contrast, allows the identification of edges. Again, this network, this layer then fires to the next layer, and this combination of edges then leads to the recognition of shapes. And combination of shapes then leads to the identification of features, like a mouth and a nose or eyes in this example. And logically then the combination of these features may then allow facial recognition, in this case, recognizing that this is an image of George Washington. Now, current deep learning algorithms have an architecture and are used on computers with such a computational power that things that look alike, like chihuahuas and blueberry muffins, are now better recognized and quicker recognized and more reproducibly recognized by these deep learning algorithms than humans can do. That means that this deep learning infrastructure is ready to recognize the subtle differences between normal and neoplasia in endoscopy, for instance. Now, deep learning in machine learning for endoscopy has a number of pitfalls. The most important pitfall is that generally we don't have as much as images with delineations from endoscopic targets to really do as extensive deep learning approach as with the underlying database. So the limited number of images pose us at a risk that we circle around in this data set too much. The approach that is generally used is called internal cross-validation, which is first of all, a very legitimate and good tool to optimize training and validation in your data set. Basically, what you do is you divide the number of images you have in a proportion that you use for training, and then use, in this case, 20% for validation. But this 80-20% cutoff you can put at different levels. Actually, you can do this 4 times with different images used for training and different images used for validation, and then use the average score to find the optimal relationship between your data and your outcome. Now, internal cross-validation is a very good tool because all data are used for training and all data are used for testing. The danger, however, is that if this data set is small, and if you only have a single data set, especially if you do too much cross-validation, not a 4-fold cross-validation as in the previous example, but a 20-fold cross-validation, which is clearly inappropriate. The thing that then happens is that you just circle around your data set too much. You will find the optimal distinction between neoplasia and normal, but that's because you not only modeled relevant features, but you also modeled all the background noise in that data set. The model is then what we call overfitted. It works perfect on your training set, but it performs lousy if you test it in another set. And that's actually the crucial thing in machine learning studies. You need an external and independent test set to see how well your model is actually performing, how well your algorithm is trained. But logically, that should be done on a new data set. That means that the algorithm should not have seen any of the images in the training phase. And logically, this not only holds for images, but actually also holds for patients. So if you would have 20 images of a single patient, you cannot use 10 images for training and then put the other 10 images of the same patient in a test set, because logically, those images have too much resemblance to the ones that went into the training set, and you will get a biased outcome. Ideally, such an external test set should come actually from another center, preferably multiple other centers. So why is this so important? What's the problem of a single data set? Well, here's a nice example of Volvo developing an algorithm to detect animals at the side of the road, avoiding the Volvo car crushing onto a moose or onto these two elks. As you know, Volvo is a Swedish company, so logically they had a lot of images of elks and moose. When they then took their cars with their collision algorithm avoiding tool to Australia, they ran into trouble. They bumped into all the kangaroos. Logically, because a kangaroo has a totally different shape than a moose or an elk, and also moves quite differently across the road as a reindeer or an elk does. Another thing with this deep learning approach is that it is completely a black box. We have the computer extract the relevant features that work, but it will extract any feature that works, even if it's conceptually totally false. So here's an example of a deep learning algorithm to recognize dysplasia in histology biopsies. And you find out that the model is really 100% accurate, which is amazing. And then you look under the hood of this deep learning algorithm and you find out that the most important feature has nothing to do with the histology, but actually with these green dots. The green dots that were placed by the pathologist marking areas of dysplasia. And since the pathologist assessment was used as a gold standard, it becomes like a self-fulfilling prophecy. It bears no relevance to actually histological distinction. Or here an example of an algorithm trying to identify chest X-rays with pneumonia. It turned out that the presence of a central line or a respiratory tube or images that had a low resolution or had the word portable on screen actually predicted the presence of pneumonia, which is completely logical because these are all features of patients on the ICU, in which we generally obtain portable chest X-rays. And these are completely different, therefore, than of a chest X-ray that is obtained in an outpatient patient that comes to your outpatient clinic. So bear in mind, deep learning models use all the information provided, even if it is trivial. So here are the 3 rules how you should appraise studies on computer-assisted detection or on machine learning. These algorithms need to have shown their merit on an external test set. And then this external test set should actually pose a true challenge for endoscopic detection. Makes no sense to use an algorithm to find big, bulky cancers. You need to challenge the algorithms with those lesions that will be missed endoscopically by endoscopists. And therefore, any performance score on a test set bears no relevance if you don't know how well the endoscopist would have done if they would have looked at these images. You need some kind of reference. So back to our Barrett's algorithm that we published in Gastroenterology, trying to find subtle early Barrett's cancers, in which we used a large test set for pre-training our algorithm, and then used 2 independent data sets to train and to do refinement training. do internal validation to optimize the hyperparameters in our algorithm, to then arrive on a deep learning-based CAT system that we subsequently tested on 2 independent data sets, obtained in 3 other hospitals and another 4 other hospitals, and containing really very subtle images. So this is where most of the machine learning publications stop. They just present the results of the internal validation, and then a sensitivity of 88% looks pretty good, but it makes no sense in only reporting how well it works on your training set. So this is why you need at least one external test set. And in our case, we had actually an increase in sensitivity if we used our deep learning algorithm on independent test sets. Now, a 93% detection looks pretty good, but it only bears relevance if you know how well you would have done if you would have looked at these images without an algorithm. So for that reason, we had this data set assessed by 53 endoscopists, again, very subtle lesions only. And then it turned out that the endoscopists were clearly inferior to the detection rate by the CAT algorithm. And if you then depict sensitivity and 1 minus specificity, here is where the CAT algorithm is clearly outperforming all the other 53 endoscopists. Now, this is not to show off our study results, but this is to learn you how you should critically appraise CAT studies. Stop reading if the paper does not present an external test set. Look at this test set and ask yourself the question, was this really a true challenge from an endoscopic perspective? And then, is there any kind of reference? A 99% performance rate really doesn't say anything if you don't have a reference. Now, at this meeting and in clinical practice, you may have been approached by companies actually promoting their use of their colon polyp detection algorithms. There's colon polyp detection algorithms, and there's colon polyp characterization algorithms. And all leading endoscopy companies and Medtronic have one of those systems available. So how should you critically appraise such commercial CAT systems? Many of these CAT systems do not give you the underlying preclinical work because of IP-related issues, and only confront you with clinical outcomes. Well, these clinical outcomes then logically require studies with a control arm and with a randomized design, which many actually have. And you still need to be careful because there's bias luring at multiple levels. Even if you randomize your patients, you should look if the endoscopists were randomized. And then there's effects like, how do endoscopists perform if they know that an algorithm is actually supervising them? There's a learning curve effect, et cetera, et cetera. Don't bother with that. The only key question I'd like you to ask is, does the presented outcome bear any clinical relevance? Is the CAT system really giving me something that the patient will benefit from? So here is a slide kindly provided to me by Yuichi Mori, in which the 6 randomized controlled trials for colon polyp detection have been summarized. It's a meta-analysis actually published in 2 different papers with clearly an advanced detection rate of adenomas, adenoma detection rate of 25% of the control arm, and a mean of 37 in the AI group. All studies actually showing statistical significance. As I said, the key question is this leading to picking up relevant disease? And actually, if you look at all these studies, you will find that actually the only statistical difference in these studies is the pickup of very small polyps. You will find more small polyps, up till 5 millimeters, in the CAT group versus the routine group. But you will not find difference in carcinomas, sessile serrated adenomas, or advanced adenomas. Actually, if you look at the point estimates of cancer, serrated adenomas, and advanced adenomas, actually the point estimates are higher in the sham control group than in the AI group. So that means that from my perspective, it's questionable if these tools are picking up relevant disease. Now, there is one randomized control trial of a detection CAT in colon that does report a clinically relevant difference. That is this study by Gong et al., published in Lancet Gastroenterology last year. It's a Chinese study coming from the city of Wuhan, a city that really got a bad reputation since it was the origin of the current COVID pandemic. But 6 months before the outbreak, they randomized 704 patients between AI and non-AI, found an increased rate of adenoma detection, and also a higher rate of larger adenomas being detected in the AI group. The EndoAngel tool that was used for this, however, is not a polyp detection tool, but it is a quality algorithm tool. It follows you while you're on your way to the cecum. And once you are at the cecum, it recognizes the cecum. And you say, okay, you've reached the cecum, now we can withdraw. And then it will follow the speed in which you withdraw your endoscope. And if you withdraw too fast, you'll get into the red area and you will be urged to slow down. And very important, if you miss an area, if your scope slips and you fall behind here, it will say, oops, you missed something. View is lost, please return. And it will give you the last 10 frames it had from where you were adequately looking at the column. It will tell you when you've reached the point where that was, and then you can pull back. Now, such quality algorithms may also help you to find blind spots. Here's 2 of these blind spot quality allocating tools in which during your gastroscopy, it maps what part of the stomach you have seen. These are 2 different algorithms, and you can see actually here that it's gradually expanding, but you still need to have a look at the lesser curvature, or here at the lesser curvature, the normal area of a blind spot during gastroscopy. So I think machine learning in endoscopy is really here to stay. I've given you some tools that may help you to appraise studies in this field and to ask critical questions. But I do think that it may aid in the endoscopic detection, which is sometimes difficult for very subtle lesions like early Barrett's cancers, where we are interested in, but also early gastric cancer or sessile serrated adenomas. And I'm also convinced that some of these tools may help you to make decisions during your endoscopy, either not to biopsy, not to resect, or to resect and discard, or not to resect if there's clear signs of deep submucosal invasion. But I think the biggest impact will likely come from algorithms that will monitor your performance, that will be telling you when you're doing a poor job, and that will be pointing towards areas that you may have overlooked and require more of your attention. So this is really something that will get into your endoscopy suite and will improve the quality of your endoscopy as well as the quality of our training. Now, the downside of all of this is that it will also increase the number of irrelevant findings. The summary of the randomized trials on polyp detection actually suggests that that's already the case. And some of you may have heard some of my lectures in which I express my worry about the expansion of overutilization of endoscopy in our profession. And logically, this is something that somewhere is counterintuitive. Machine learning will improve the quality of endoscopies, but we will still have to balance what type of endoscopies we do and how we proceed with the information we get from this. So if you want to learn more about this, our group has published a pretty practical paper in GUT last year, a practical guidance in how to interpret a novel field of machine learning in GI endoscopy. You may want to check out this paper for some additional reading. Thank you very much, and I'm looking forward for any virtual questions you may have. Thank you very much for your attention.